Share start. Share the PPT.
Very good evening to all of you. It's a proud privilege for me to welcome you all on this inaugural online program of FOGSI ICOG Guru Mantra for this year, under guidance of our FOGSI President Dr. Bhaskar Pal sir and ICOG Chairperson Dr. Sheila ma'am. So let us have blessings of Ma Saraswati. Yes, video.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय ॐ शान्ति शान्ति शान्ति.
After blessings from Ma Saraswati, let us all be ready to collect pearls of wisdom from our respected gurus, legends in the field of obstetrics and gynecology, Dr. B.P. Pillai sirs and Dr. Suchitra Pandit ma'am. And before we start, we want to take blessings from our respected FOGSI Chairperson, FOGSI President, Dr. Bhaskar Pal sir. Let me have that CV of Dr. Bhaskar Pal sir.
Not required. Madam, not required. Thank you.
Ma'am,
Sir, not required.
Your blessings, sir, your blessings.
Thank you. It is not blessings, it's my good wishes. I don't
Yes,
have
sir.
the audacity to give blessings in the presence of so many seniors. It's
Yes,
my
sir.
pleasure to be here. You can stop sharing, it's not a problem. I think I congratulate Dr. Sheila, my dear friend, Dr. Sheila Mane, and Pratik Tam, and Dr. Sanata. And it is the best wishes for the first program of the new team. And it's my pleasure to be here. I think continuity is very, very important. So it is no point a new team coming in and starting a fresh, changing whatever was running new. So in ICOG as well as in FOGSI, we will continue doing things which have already been a success. So I think today's great Guru Mantra program with respected Dr. VP Paili and Dr. Suchitra Pandit, I'm sure it's going to be a great program. And thank you very much for having me here. And I think it is important that we make the introductions a little shorter and make the academics get on to the academics as soon as possible. Thank you very much.
Thank you so much, sir, for your kind words.
Thank you. Thank you, sir.
Dr. Shashi.
Yeah. A great opportunity to be the august company of stalwarts. And here I have the privilege of introducing our chairperson. A frightened captain makes a frightened crew. Here the captain and crew all are fearless. So Sheila ma'am, a big round of applause for Sheila ma'am.
Thank you.
And she has been vice president.
As Dr. Bhaskar said, no introduction. We all know each other very
Madam,
well.
3 lines for you. Skilled, focused, and unbiased. That's all for you, madam. Please give us your pearls of wisdom now.
Yeah,
Yes.
thank you. So, good afternoon, everybody. And it's my, I feel really, privileged today as a chairperson to start my program, and that too the first program as Guru Mantra. And I thought of starting is as a Guru Mantra because we are an academic body, and the Guru's blessings are always very, very important, because we always say Gurur Brahma, Gurur Vishnu, Gurur Devo Maheshwaraha, Guru Sakshat Parabrahma, Tasmai Shri Guruve Namaha. So let us all hope that the whole year we are blessed with everybody's best wishes, and we will be able to do the programs very efficiently. And I thank Dr. Bhaskar for joining and giving his best wishes for our program. And I'm very happy to see that all my governing council members have joined. And it's again a privilege to see so many senior amongst us. And I think that will be definitely very, very beneficial for all of us to take and to carry our work forward. So today's is Guru Mantra, and I hand over again the platform to Dr. Shashibala to take it forward. And once again, I wish a Happy New Year. Even though we met in Delhi, I must have not met everybody there. And really, really need everybody's support to make this year, every year, as
Yes.
Dr. Bhaskar said, should
Yes,
be
madam.
fruitful. So let us try to do as much as possible with God's grace. Thank you.
Thank you, ma'am. Under your leadership, we all are united and we will work very hard to
Thank
take
you.
ICOG to greater heights. So I request our FOGSI Secretary, Dr. Suvarna Khadilkar, to say a few words of.
Okay. So,
No, Dr. Suvarna,
Dynamic
I think
secretary.
I will. There is no finish line to.
no,
Is Madam there?
don't show
Yes.
any
Naga,
CVs
don't
as
project
Master
any
rightly
CV. This
said.
is just a
Okay.
best wishes, so don't project any CV.
Okay,
Shreya?
madam.
No, no need for CV and no need for any introduction, as Bhaskar rightly said. But at the outset, I want to really congratulate Sheila for having this first program of her year as chairperson. And I want to congratulate the past chairperson, Dr. Parag Biniwale and Sarita, whom I just saw. They are logged in also because they are also equally interested in all the academic endeavors that are happening here. And I think I saw the topic, and I know that Sheila is so much passionate about PPH.
Mhm.
So she has started her tenure with her
Yes.
favorite topic, PPH. And I see two renowned obstetricians, Dr. VP Paili. He's very well, stalwart in the field of obstetrics and gynecology. But I must say he is very innovative. I'm very fortunate that he wrote a chapter in my book, and all his innovations are there in my book on PPH. And sir, I thank you from bottom of my heart to that you contributed it, and all of you will hear from him. Hear from the master, a radical change is required in our management of PPH. And Dr. Suchitra is going to say, can obstetrics gynecologists play a role in preventing NCDs? I think we obstetricians start from the fetal origin, fetal origin of adult disease. So we really play very important role and further on. So with these two words, I also compliment Bhaskar for having the entire ICOG team here who was so eagerly waiting for him to join. And of course, the First Lady Sita and everyone, I can see so many others who have joined, Dr. Durga Das, Dr. Vidya, Dr. Pratibha, Subhash. I think you all are all fresh after a break in Lankavi. And I can see so many Kanchan, Lakshmi, Dr. Saroj Singh, and Kanti, and everybody, Shashi Bala. And I'm
Thank you,
really
madam.
happy that Dr. Sanchita Dubey also I see. So Dr. Deepa, Dr. Deepika, I wish you all the best. I'm sure these two enlightening lectures are going to be really very helpful to all the audience who is logged in. Thank you so much.
Thank you,
Thank you,
ma'am.
madam. Thank you, madam. Now I would request Dr. Sadhana, ma'am.
Yeah.
Strong work ethics and professionalism and knowledgeable. That's Sadhana, ma'am, for you. Sadhana, ma'am, welcome. Need you to
Thank
say a
you,
few words.
Shashi, and I send greeting along with our all ICOG office bearers, our newly elected Dr. Chairperson, Dr. Sheila Mane, and Pratik, who is working very hard, a very meticulous person. And today is the inaugural Guru Mantra. So, as a college, as an Indian, we always start from seeking the blessings from Guru, and rightly. We have the first series, that is Guru Mantra, because we want to seek blessings and we want to seek wisdom from our gurus who have really worked a lot in the maternal health as well as the youth health. So it's great to have Dr. VP Pelli and Dr. Suchitra Pandit as a eminent gurus in our today's Guru Mantra. And my greetings to all. Hearty congratulations. We welcome again all new GC members who have a very senior teachers like Dr. Saroj Singh and Dr. Shashi Bala, you are the convener, and all the GC members.
Thank you, madam.
So we look forward to great learning, not only in this program, a whole year we look forward to refresh and rethink learning from the platform of ICOG. With regards to our all past chairperson, Dr. Parag Biniwale, Dr. Lakshmi Srikhande is with us, and we seek their blessings for ICOG activities as well as their guidance. Thank you very much.
Thank you.
Thank you so
madam.
much, Dr. Sadhana. Dr. Pratik, Dr. Pratik, you want to say something?
Yes, he's confident and passionate crusader, our secretary. Please welcome
Yes,
Dr. Pratik.
our secretary, sir. Silent worker,
Yeah.
meticulous.
I think Dr. Parag, I would just like to say that as a past chairperson, I would like you to.
Yes.
Yeah, Dr. Parag and Sarita, if both of you are there together,
Yes,
together
yes.
only if you can, both
Welcome,
of you.
sir. Welcome,
Yeah.
Dr. Parag.
Welcome, sir.
Thank
Dr.
you.
Parag.
Yeah, thank you, Dr. Sheila. Good afternoon. It's indeed a pleasure to be attending the Guru Mantra series and the first program of the year 26-27. And it is heartening to see all the governing council members so enthusiastic. And I sincerely appeal to all of you that this enthusiasm should continue throughout the year, because then that will bring up the ICOG to a large extent. So Dr. Sarita and I, we both of us are here in the ICOG office. We are conducting the exam. So we just stopped the exam for 5 minutes just to wish you all the best for all the activities which are planned this year. Thank you
Thank
very
you.
much, Sheila, and the entire team.
Yeah, thank you. And
Thank you.
we
Dr.
wish all the
Pratik,
best to
please.
all the students who are appearing for the exams on behalf of ICOG.
All right.
Yeah.
Bye.
Dr. Pratik, please.
Yes, madam. Good afternoon,
Yes,
everybody,
yes, sir.
and thank you for joining this inaugural episode of ICOG Guru Mantra. When Dr. Sheila Mane and myself were planning the activities of ICOG, she was very much insistent that we should have at least two programs in January after we take over at AICOG Delhi. And the first one, she wanted it to be the Guru Mantra, where we honor our legendary gurus of OBGYN. And we're privileged to have two stalwart teachers here present today, and we're going to learn a lot from them. Thank you to Dr. Sheila Mane ma'am for wonderful conceptualization of the idea, and to all my governing council members for executing it so beautifully. Thank you, Nilima, and everybody in the office for coordinating the entire program so well in such a short space of time. I will not take it any more time further, and I thank everybody who is here in attendance. Over to the organizers again.
Thank you so much
Thank
for
you.
your kind words.
Thank you.
Uh,
Yes, there
I
is
think
no, Dr. Saroj, there is no
Yes.
finish line to learning. So I'll request you to conduct the first session of the academic session.
Okay. So let us start with the first session, in which Dr. VP Pillai is going to discuss about PPH, something new, and we are really very happy that our ICOG chairperson, Dr. Sheila Mane, has decided this particular subject, and we all know that we call her as PPH lady. And I invite Dr. Sheila Mane ma'am for as a chairperson for this session. Can we have CV of other chairpersons also, please? Our next chairperson is Dr. Achla. Dr. Achla Batra, I think she has joined. Dr. Achla, she was NARCHI president, and she is ICOG in governing council ICOG for last 2 years also, and very active senior teacher, and so many research work she has done. Our third chairperson is Dr. Pratibha Singh. I request Dr. Pratibha Singh. She is consultant laparoscopic gynecologist and IVF specialist from Bhagalpur. So all the chairpersons, we request you to please carry on with this program. CV of Dr. VP Pillai, sir.
Good afternoon. Yeah. So once again, dear friends, it's my proud privilege to introduce Dr. VP Pillai. Sir is a National President, Society of Vaginal Surgeons of India, and I must say that we are going to have the workshop in Bangalore. And past President, Kerala Federation of Obstetrics and Gynae, previous state coordinator of confidential review of maternal deaths in Kerala. And I must tell you that the whole country has learned so much from this experience of Kerala. And currently the consultant at Rajagiri Hospital, Lave, Ernakulam district, Kerala. And all of us, we know his special interest, high-risk pregnancy, particularly endoscopy, pelvic floor, and urogynecology. I know that the list is never ending if I have to speak about Dr. VP Pillai, because I think we have really learnt a lot from you, sir. And it's my proud privilege today to have you as my first speaker when I'm starting my ICOG session, and that too as a Guru Mantra. So really need your blessings for our whole year of this ICOG academic activities. On behalf of everybody, all my governing council members, Dr. Sadhna Gupta, the vice chair, and Dr. Parag, past chair, Dr. Sarita, the vice chair elect, and Dr. Ashok Kumar, who is the chair elect, and all my 25 GC members, we welcome you for this Guru Mantra Forum. Over to you, sir.
Thank you very much. It's a great honor, Sheila, Bhaskar, Pratik, Parag, and all of you over there who have given me this honor of starting off your New Year program. And I should admit, I deliberately chose the topic related to PPH because we have the PPH lady there going to guide us for the whole year. And not only because of that, because it is so relevant. And I personally feel that there's a lot of change required in our attitude towards PPH. That is why I chose this topic. So if I may be permitted to share the screen.
Yeah.
What I thought of bringing it to your attention is this thought process which goes through my mind very often. That a radical change is required in our approach to PPH. Why did I think like that? But before I go to that, I just want to make these disclosures. In the course of my presentation, I will be talking about some of the innovations I myself did, but I can assure you I don't take profit out of its sale. Hemorrhage is still the leading cause of maternal mortality and morbidity globally. Every platform you hear about it. But are we adopting new innovations with enough speed in our response to PPH? That is what concerns me. How many maternal lives are lost due to this delay? That people don't think about.
Sir, can we have a slideshow? We are not.
You are not able to see?
No, sir.
I'll probably close and share again. Are you able to see now? No?
No, sir.
I think after share, you'll have to click on the presentation and then again on share.
How about it now?
No?
No?
Yes, sir. Yes.
Are you able to see?
Yes, sir.
Okay. My point is that we are not adopting the new innovations with enough speed in our response to PPH. That's why I thought of putting the caption of the talk like what I did. I hope you can see the slides, Sheila.
Yes, sir.
Yeah. How many more maternal lives should be lost before we adopt these things? That's my question. Sorry, anybody controlling this? I cannot change the slide now.
So click on the slide and then go to the arrow, sir.
Okay,
Yeah.
okay. But the fact is, most of these developments I am going to talk about are from the developing countries. Basically, even from our own country. My thought was, won't the attitude of the international bodies like WHO and FIGO change if such deaths happen in developed countries? Because when the need comes, bodies change their policies. Let us recall what happened regarding COVID pandemic. The mRNA vaccine that was developed was fast-tracked and put to use in a few weeks' time rather than years as it would have been. Similarly, if we know that there is enough need to be urgent and to fast-track, I think we will do. For example, we are supposed to have about 2 lakhs plus maternal deaths every year. And out of that, nearly 27% due to hemorrhage. which works out to be about 70,000 women dying due to hemorrhage every year. And if only we know that, from our experience, we are convinced that if only the suction cannula and the clamps that we have developed are used more widely, many of these deaths can be prevented. That is why I thought of this caption, but there are other points as well. A radical change is required in the approach to PPH by the practicing obstetricians and by the governing bodies like WHO, FIGO, and Seagates Foundation and all that. The other point I wanted to highlight is we should empower the person conducting delivery to initiate the first steps to control bleeding. Be it a nurse, a midwife, or a doctor, or even a nursing assistant should start the action because every minute counts. And if you delay the specific action by even few minutes, that can make the outcome the worst way. The areas where fast tracking is required, as I can think about, first thing, a new flowchart is required, is recommended. And this is what we would suggest. Whenever delivery occurs, active management of third stage of labor should be a must. And if you see heavy bleeding before placental delivery, think of it as most likely traumatic. And local treatment like pressure or clamping will be the one to answer that. But if placenta is delivered and then heavy bleeding occurs, think of it as mainly two reasons, due to two reasons. One, it may be a tonicity of the upper segment or the lower segment. But the person on the spot immediately applies bimanual compression and asks for, depending on the finding, either a suction cannula or a clamp. And if you do this properly, the bleeding will stop. That is our experience. In the last nearly 7 years, that is our experience. And that is why we are batting for it. The best approach is prevent, prevent, prevent. And for that, we need active management of third stage of labor in every delivery, be it vaginal or cesarean. But when it comes to the implementation of the active management of third stage of labor, there are so many recommendations. We have standardized it. We said it should be 5 units of oxytocin diluted to 5 ml given over a period of 5 seconds as the first aid at the delivery of the anterior shoulder or within 1 minute of delivery of the baby. Add to that another 10 units IM. Because WHO delayed adopting this IV, rather, even though they said 10 units IV bar IM, and the anesthetists object to it, IV oxytocin is withheld and given. So my suggestion is 5 units IV, more than lakhs of babies have been born in Kerala after we adopted in 2013, and no occasion of problem from 5 units IV was reported. So in high-risk cases, we can add another 20 units in 500 ml and give it like that. The other components of active management of third stage of labor you adopt. People talk about carbetocin as the wonder drug. It is useful, but we don't find it more effective than oxytocin, which is given at the right time, especially the IV oxytocin. Of course, the advantage of not needing refrigeration and the advantage that only one injection is required are there. So I'm not against it, but the cost is a factor. Additional oxytocin will be used as required, no doubt about it. The second point I wanted to highlight is we should talk the same language regarding fourth stage of labor. Maternal death due to hemorrhage in the fourth stage of labor is a reality, and I think we should say 2 hours and not 1 hour as the duration. And every half an hour after that, the person on the spot should be observing the pulse, the blood pressure, whether the uterus is contracted or not by expressing the fundus of the uterus, and see if there is a blood flowing between the thighs, and also the contracted state, not just pulse and BP. This has to be done by the nurse on the spot. And we should have a stamp like this to record it at the designated time. Otherwise, people will say, they will look at the face until the patient collapses and then goes to shock. The entity of lower segment PPH has to be recognized I remember the first time this term was coined and I was asked to give a lecture on that was by Sujitra only. She asked me to go and give a lecture on lower segment BPH, a new concept at that time. But there's no doubt, it's a reality, especially after we have started to use prostaglandins, induction of labor, Foley catheter, and all that. And the new concept about labor, that you can allow the head low down for 1, 2, or even 3 hours. That means lower segment BPH is a reality. We should recognize and act on it. And for that, bimanual compression and cannula or the transvaginal urinary clamp has to be employed. Bimanual compression like this. And if you have the cannula, you just see what it does. If you have the cannula, insert it into the uterine cavity and create the negative pressure, you just see the way the myometrium contracts. So I don't know why there should be further delay. This is a cannula. We can have a flexible cannula and it doesn't traumatize. We should empower, if it is a midwife by the side of the patient, to use it. Then only you will have immediate effect and arrest deaths due to that. Clamps, which we have developed, transvaginal urinary clamp, like this one, the first model, and we have further developed on that. But we can inspect the cervix with cervical inspection set, which should be there in every labor room. And once you apply the clamp, blocking the uterine arteries, it will go like that. How it is applied? It will apply pressure at the site of the entry of the uterine artery on the side of the uterus and stop the bleeding. And if you look at the way we can apply it, even a nurse can apply it. Hold on to the anterior lip of the cervix with a sponge holder. Hold on to the posterior lip of the cervix, and then the clamp is inserted, one blade into the cervical canal, the other into the lateral fornix. Once you have reached the lateral fornix, the open clamp is pushed higher, further, and then clamp so that it will reach the level of the uterine artery and stop it. Even a nurse can be trained to do that. That is our recommendation. So you can apply the clamp as simply as that. It should be done promptly, then only you will get the desired effect. This has already been published in the European Journal. We have modified the clamp to make it into a T-clamp, T-shaped end, unlike the previous one, which was an L shape. A T-shaped end like this will make it actually more easy for the nurses to apply it. And this is how it will look. This is again, there should be a gap between the two. It's a shorter version at right angles to the, and this is how we apply it. Same thing as that, but anterior and the posterior lips are held. Then the clamp is applied at 3 o'clock and 9 o'clock. And any midwife with reasonable experience can do it. And our recommendation is that the person on the spot conducting the delivery should be able to apply it. Go up to the arterial fornix, push further, and then clamp it. It doesn't need anesthesia, and that is what we recommend for this. This is how it will apply. Between cannula and clamp, we usually recommend that the upper segment is flabby, you go for the cannula. Lower segment is flabby and the upper segment contracted, go for the cannula. But many times we may use both because it is not always easy to differentiate between the two. If the bleeding not settled with clamps and cannula, check if they are applied correctly. And if they are applied correctly and still bleeding, take her to theater. I can assure you that in the last 7 years, we did not have to take anybody to the theater from the labor room because of this. During cesarean, people usually ignore the fact that there can be excessive blood loss, not from uterine artery alone, but from big sinuses like that, welling up. You cannot see where you are. And the moment you apply this clamp, without making sure, without bothering whether the bladder is there, ureter is there, you can apply the clamp, stop the bleeding, and then proceed further. That is what we should do. So this atraumatic clamp can be applied like that. And then I would mention the iota clamp, which we developed for PAS, placenta accreta spectrum, rapidly becoming a major threat all over the world and more so in our country. And the guidelines are very reluctant to adopt the clamp which we published in the International Journal and still not being able to use it because it is so cheap, and we have used it in hundreds now, and without any adverse effect reported of injury to vena cava or aorta as a result of that. A simple clamp like this will help to reduce the bleeding, and it is very simple for practicing obstetricians to apply. You don't need a vascular surgeon for that. So the baby is delivered, uterus is exteriorized, you expose the posterior abdominal wall over the lumbar vertebrae where you can see the aorta bifurcation. And just above the bifurcation, you lift up the aorta without any dissection. Lift up the aorta with a Babcock and apply the clamp, which will stop the bleeding. Check that it has stopped the bleeding by palpating the common iliac artery pulsation, which would automatically stop once you have applied it. So a practicing obstetrician should be able to do that. Whether you plan it, a PA surgery or unplanned surgery is required, this should be there available in every obstetric theater. That is our recommendation. Once you do that, the advantage is, even in a percreta placenta like this, once you have applied the clamp, you can see how bloodless the dissection becomes. You see, you can separate the uterovesical fold and the bladder from the percreta placenta with minimal blood loss like that. That is why we recommend it. There are other changes also required in our recommendations for PPH. We should stop talking about golden 2 hours. There is no golden 2 hours, not even golden 2 minutes. NISG, non-pneumatic anti-shock garment, used for transfer of patients, and stop detailing condom tamponade, which we have stopped. Bakri balloon also. If there is nothing else, of course, use it. But that should not be our first line teaching. Internal iliac artery ligation, not easy for every obstetrician, can easily learn, but not required in atonic PPH. And whole tube coagulation test, very simple, should be promoted in every labor room rather than rotum and other things which are not available. And spread the message that cryoprecipitate is a richer source of fibrinogen, and cryoprecipitate is underutilized. So we should start using it. Every labor room should have a PPH trolley, not the cart, the cardiac arrest cart. A PPH trolley, which will be as simple as that, a suction and a tray full of some of these instruments. That's all. But every day, the nurse should check it for the drugs, and we should promote institutional delivery, practice active management of third stage labor, and PPH drill should be practiced at least once monthly. So these are the radical changes I would suggest for your consideration. And thank you very much once again for this opportunity to share our thoughts with you regarding the management of PPH. A radical change is required in our approach. And I hope that, at least in our country, and the initiative of FOGSI and ICOG, more and more obstetricians will have this chain thinking. I'm open to any questions. Thank you very much.
Dr. Pratibha can conclude.
So, thank you, sir, for such wonderful and amazing and very inspiring talk. And good evening, everyone. First of all, I just want to thank ICOG Chair, Dr. Sheila Mane ma'am, Vice Chairperson, Dr. Sadhna ma'am, Secretary, Dr. Pratik Tambe, for giving me this opportunity to chair this such prestigious talk in this inaugural session of Guru Mantra. And what sir has highlighted today, the different types of clamps, which is so important. And the main future of PPH management lies not in heroic last minute measures, but in system like standardized drills, then bundle, then checklist, and finally the accountability. So very clearly sir has highlighted everything. And we all know, we must remember that PPH is predictable, preventable, and also treatable when managed with preparedness rather than panic. So this is our responsibility. I think all of our obstetrician, this is our responsibility that we should ensure that what we learn today should transfer into the safer motherhood tomorrow. So that is very important, and I am really very happy today to learn so many things from sir. And once again, I want to thank so much for giving me this opportunity. Thank you so much.
Thank you. Thank you, sir. Sir, as you said that I think the first or second slide you mentioned that if this would happen in developed countries, then the other methods would have been accepted. Now we know that the suction cannula, which we are using very effectively in our country, and all of us are happy about it. But I mean, to bring it at that level that where it is easily acceptable. In fact, it happened today only that I met a group of people from Ethiopia, and they have approached me saying that there is, yeah, we noted that time is up. Sir already finished in time. So, and the PPH is a real problem there. They do not even have the basic facilities. So, I think again we have one more opportunity to collaborate with other countries. That's what I thought. But these suction cannula is not mentioned in revised WHO guideline. And all of us are so much experienced. I think we would like you, sir, to guide us that how we can have some proper trials and the publications where we'll be able to impress the FIGO, WHO, as well as the ICM. I would like to hear from you.
Actually, it's not at all difficult for us to do a trial. We have it in mind. We will do it. We have just applied to the CTRI for that, and we will come out with it. The idea is not as treatment for PPH. It should be to prevent excess blood loss.
I got it. Yeah.
That is what we should, and that is what we are planning. We have applied for a CTRI as a number once it comes, and then we will be initiating that, a multi-center trial. First, initially, of course, single-center trial to show the effectiveness, and then a multi-center trial. And hopefully, we'll be able to convince the international bodies. See, Gates Foundation did a trial involving millions using condom. And they finally found that it's not as superior as people claim. We have to show that the cannula of different forms works. Of course, my only hope is that because the Americans have brought out the JADA device, which costs only 1 lakh something per unit, which is disposable, whereas ours will cost only 100 plus or maybe 150 rupees. That's the difference in the cost.
Sir, yeah. One submission, sir. Even the JADA system, because when we were making these guidelines with WHO, like there are studies which JADA system where it is used, and like that we are not able to. I mean, yeah, we are looking forward now, as you said, that unless and until we have more publications and more studies, which we have to highlight now. And that JADA is so difficult because it has to be inserted. One thing is from below. And if the os is closed, even during after cesarean, if we introduce, it will be difficult. Anyway, I don't want to go into the details. So how do we enforce our innovations so that, it will be available globally and particularly the LMIC countries? As I told you today, only I met a person from Ethiopia, a Gandhi hospital in Ethiopia, that is Addis Ababa. So,
as I told you, we have started to think in that line, and then hopefully we'll be able to come out with the answer. Thank you, Sheila.
Can I ask a question, sir?
Yeah, please.
Sir, we have an option of this Samarthram and the Panikkar cannula, but what you said was number 16, 18. So do you imply that the Carmen cannula of that size can also be used?
You asked me personally, I won't agree to that because that is not the ideal to do. We should have multiple holes covering the distal 4 inches or 10 centimeters and Carmen cannula with one hole like that. If nothing else, of course, that may work, but I don't think that by itself is good.
So when we do the studies, it should be the standardized cannula.
Yeah.
So that way, Samarthram cannula has all the options, different sizes.
Samarthram, Panikkar, these are the 2 friends who have come out with it. We also have done some work on it. So we'll do the work and then let you know. Thank you.
Yeah. Thank you, sir.
I would thank you, sir, for a brilliant talk. I just want to say we are talking of FIGO and we're talking of WHO. Are we using it all over India? I am from Delhi. And I mean, it's not very common to use these cannulas or to use the clamps. So I think first what we need to is start from home. I think FOGSI, ICOG, like this webinar, we should have many more to familiarize everybody with cannulas use. We all know about it, but everybody is not using it. It is so good. South has decreased their PPH mortality so much by this, but still it is not popular. So I think first we have to look into our own family before we go out. And this talk has given so much food for thought about IV oxytocin and the clamps and 2 hours also, like we all know 2 hours, but does everybody till the periphery knows 2 hours? So I think it's our duty, prime duty, that we go everywhere and spread the word around PPH and what has to be done. And such cheap devices are there which can be used.
Thank you. Thank
That's
you,
the point,
Achala.
actually. Achala, you have emphasized the right points. I think we have to start from home, and I hope that Bhaskar is there, and Sheila certainly is here, and we hope that we will take it up more seriously. But we need studies, we need publications. I don't agree with bypassing all that requirement. We need to do that. We have to go scientifically. But as you said, we have to start at home, and already there is so much experience and so many publications, Sheila, already. Of course, they are not in the international big journals, but there are so many actually already there.
Thank you, sir. I hope that definitely as the thought is there and everybody is thinking about it, and with your guidance, I think under academic advisory committee in ICOG, which I have started, I have also taken an innovation cell there. So through that, I think through that cell, we should see to it that our own indigenous innovations which are happening in India, we should see to it that how we take it forward and make it, through publications, of course, it has to be evidence-based. So thank you. I'm sure that I can see large number of people have joined and really happy to see that almost 160 people have joined, and that's really a good number. The message is conveyed, and I agree with you, Dr. Achala. Thank you, sir.
Thank you very much.
For accepting our
Thank you so much, sir. Thank you
Thank
so
you.
much, chairperson. Thank you. Let us proceed to the second session. Dr. Shish.
Yeah. Now, we are striving for scholarly accuracy here in ICOG. So for that, for the next session, we have our prolific speaker and a person of repute, Madam Suchitra Pandit Madam, and she'll be speaking on can OB/GYN play a role in preventing NCDs. And for that, we have chairpersons like Dr. Arup Kumar Maji, he's most committed, and dynamic Dr. Mitra Saxena, and our energy tanker, Dr. Deepa Gupta. So over to you, chairpersons. Please introduce our madam, Dr. Suchitra Pandit. Next session is yours. Dr. Mitra?
Yeah. Very good evening to everybody. This
Mitra,
is
just
really
keep it very short because
Yeah. No,
me
I know
focus
it
more
has
on
to
the
be
topic.
very short, and I don't need a CV to tell everybody who Dr. Suchitra Pandit is. And actually speaking, we know that she has been the person who has taken FOGSI to the academic level, especially in the one area we all lack, and that was communication skills. I want to mention that because every time you have taught everyone about that, it has to be emphasized because it's very important. And today, what you're going to speak is another, opening our minds towards our responsibility, how we as obstetricians should be mindful that we can prevent NCD. I'm not going to spend time on introducing you, and the floor is all yours. And the privilege is mine to introduce Dr. Suchitra Pandit, our guru for today. Over to you, Dr. Suchitra.
Thank you so much. So let me first share my screen.
And while Dr. Suchitra Pandit is sharing her screen, I'll just speak one sentence. She is my guru who inducted me into the Mumbai Society. And it's thanks to her that I am here today as the ICOG secretary. I can never repay that debt. Thank you.
One submission from me. I must thank Dr. Lakshmi Shrikhande, who started this Guru Mantra. Okay, so that's what everybody is so innovative. So thank you, Lakshmi, for introducing this to ICOG. Thank you.
So is my screen seen?
Yes.
Yes, ma'am.
Yes, ma'am. Please go
Okay,
ahead.
so before I start, the first biggest guru, Professor Piley, I've always looked up to him for all kinds of advice, and He's always told us very, very practical things. So, sir, wonderful listening to you. And Sheila, congratulations on your first Guru Mantra. Congrats to you and your team, which includes Sadhana Gupta, Dr. Ashok Kumar, and Dr. Pratik. So you have an excellent team. And of course, Shashi Bala and Achla and all your coordinators. So it's a highly academic team, and that's what we expect from you, Sheila, this year. And when we are talking of prevention, I do agree that in our country, we're talking of treatment all the time. This happens, you do this, but why can't we think of prevention, which is so, so important? And this is one area. Immediately after PPH, our mortality is caused by NCDs, particularly hypertensive disorders, diabetes, very close on heels. So NCDs, can obstetricians reduce this? And the answer is definitely yes. We all understand that NCDs affect people in the productive years of their life and not only cause morbidity but premature mortality. And we as obstetricians play an important role because these women come to us so we can request them to come preconceptionally and try to reduce the risk to the mother and the child. And of course, if this window is missed, then screening early in pregnancy will help us to modify risks like unhealthy diets, physical inactivity, tobacco, alcohol use. Fortunately, in our country, alcohol is less, but tobacco is still rising. And very importantly, prioritizing integration of maternal, child, and newborn care with screening for NCDs, which is very, very essential. We all know what NCDs are, so I'm not going to learn that. But the several diseases which are included: anemia, diabetes, hypertension, obesity, cardiovascular diseases, stroke, cancer. Cancer is also on the rise, not so much in obstetrics, but it is one of the places where we can pick it up. Mental health, dementia, infertility, and chronic respiratory diseases. But what we have seen is, just as India is the youngest country now, we're also going to be an aging population just 10 years down the line. And unplanned urbanization and globalization have contributed to this rise. And these diseases not just target women, but they also do it for men and children and all people in all possible income groups. So today, as Indian gynecologists, we are seeing a wide range right from PCO to postmenopausal metabolic syndrome. So unless we have a strong will and motivation to constantly keep counseling patients to adopt a healthy lifestyle, we cannot proceed ahead. So therefore, screening, monitoring, creating public awareness, and these unique challenges have to be cost effective. And some of the very glaring facts, we always talk of very high incidence of preterm birth in our country, and we're leading to so many neonatal deaths, and we're talking of management of preterm labor all the time. But friends, do you know that 50% of preterm labors are iatrogenic, and the patients have to be delivered before before maturity due to diabetes and hypertension, because these are the ones which cause that intergeneration negative health impacts for the future offspring. So screening for NCDs and management are very, very effective strategies for reducing the preterm birth rates, the maternal complications, and improving neonatal outcomes and long-term health consequences. And this is what WHO has been saying for the last 5 years: reduce the NCDs. So the common ones are diabetes, hypertension, obesity. Of course, we know that with asthma, if it's well controlled, it may not increase the risk of preterm birth, but if not treated properly, can create a problem. But otherwise, we know about the thyroid issues, simple treatments, anemia, and the rheumatic heart disease, which are on the decline, but we still have our hemoglobinopathies to deal with. So therefore, let's look at the Sampurna Care. Our past president, Dr. Sunita, was talking about Sampurna Care, that primary prevention interventions for women of all age groups. So in preconception, let's start looking at the risk factors. When we are going for a wedding, instead of giving a gift or a check to the newborn couple, you should not the newborn, the newly wedded couple, let's give them a letter saying that this is a free consult to come and visit a gynecologist so that we can look at their planning. When do they want to have a pregnancy? And we can look at the risk factors. And of course, if they've missed out that window, then, earliest possible antenatal care. And if they come to us early, we talk to them about healthy diet, which our youngsters definitely need, exercise, measures to reduce the stress, the smoking. Alcohol, fortunately, is not on the rise, but young girls today are consuming some amount of drugs, young girls and boys. So, all these can create problems for not just them, but also for their babies. And of course, when we're looking at preconception counseling, we look at the other histories like the previous preterm births and the medical conditions, which are very, very important. So, antenatal care is an important factor. We understand lack of it leads to problems, but WHO says preconception counseling, please do. And if that is done, you can actually you give a lot of benefits to your patient. And after pregnancy, a minimum of 4 antenatal visits. FOGSI says at least 6, but in a better part of the our OPDs, patients come almost every 3 weeks. But at least in the public hospitals, we say minimum of 6 visits is really going to be beneficial. A detailed history, no two opinions about that. Capturing the NCDs at the earliest possible state and giving them the necessary treatment. And let's see now, WHO has constantly been talking about this preconception care. We know that this, the alarming health statistics are there. We know that so many women and their children die every year. There are stillbirths, and most of them are in the Southeast Asia. So therefore, when we know that the pregnancies are unplanned and maternal undernutrition and bad nutrition, which leads to obesity, is common in India, we are facing all these problems. So let's all join hands and look at preconception care. All the international guidelines and our FOGSI is also talking about absolute important: identify, educate, and intervene. So the preconception care is so important. And as I mentioned before, the modifiable risk factors, one is the unhealthy behaviors. Smoking, we can always tell our patients the problems that are associated. We give them behavioral therapy, or then put them on some drugs like nicotine replacements or varenicline. You can take a help of a psychiatrist or a public health which deals with these for reducing smoking. Again, substance abuse, commoner in the urban areas. We counsel them. If most of the women that I have seen will stop drinking alcohol or drugs, but those who continue, they have to stop it once they know that they're pregnant. But if they don't, we consult a psychiatrist and advise them on benzodiazepines. Now, the preconception thing is basically 5 more important factors: nutrition, look at chronic diseases, genetic psychosocial issues, infections, and vaccinations. Of course, they don't come in NCDs, but let's first look at the nutritional aspects. We talk about periconceptional folic acid at least 1 month, but ideally is 3 months before, because you want to reduce the risk of neural tube defects. But those who have got moderate risk or those who got a very high risk, we give it to them 3 months prior, and we give them a proper 4 milligrams folic acid. Of course, in India, only 5 is available. And where you are in doubt, you can give the methyl folate, because we know that we can't keep testing everybody for the MTHFR gene mutation. It is easier to give the tetrahydrofolate than do it. Role of multiple micronutrients. There's been a lot of talk in FOGSI circles about. We're waiting for the proper evidence, but we all understand that a good nutrition always will give rise to a better, implantation for the pregnancy. And again, DHA in the first trimester is not clear. We always start off in the third. So the practical points are, we've already mentioned about the folic acid. What about iron? We all know that India has got anemia. We all understand that there is poor nutrition leading to that. So why not start at adolescent age and keep talking to them of a better nutrition, deworm them, give them regular iron supplements. And of course, in pregnancy, we have the wonderful Government of India guidelines, which talks about giving iron and folic acid as well as calcium in pregnancy. and 3 months beyond delivery. But if there is anemia arising, we know that there is more amount of pph, so the proper protocols should be in place. And along with anemia, please screen for hemoglobinopathies. HB by HPLC, simple. This is the basis of the Mukta project. Please screen them and give, if they are positive, the traits. If they have a trait, then get their partners tested, because then in that situation the pregnancy should be fairly okay. But if both the partners have a trait, then you have a chance of doing a prenatal diagnosis to find out whether the offspring or the conceptus is going to be having a thalassemia major, then give them options of termination. But in a thalassemia minor, they must continue with folic acid and the regular iron supplements and deworming. And there are certain areas in India where the sickle cell is common, the Vidarbha, the Chhattisgarh district. But thalassemia, we've seen because of mixed marriages, even a Keralite patient had a thalassemia positive because her great grandmother was a Kutchi. So the third nutrition intervention today is very important in our country, and obesity is becoming an epidemic. We used to talk of malnutrition, but today we are talking of overweight and a high BMI. And therefore, we know that there are problems when they have. So therefore, multi-pronged intervention, if they come preconceptionally, great counseling, nutritional modification, the weights, the exercises, and of course, then the pharmacotherapy. But we have to individualize it.
1 second, Dr. Suchitra. I don't know.
Yes.
Is the screen big for all or only in my laptop? Is the
Is
screen
everyone
okay?
is everyone able to see it?
Screen looks fine to me.
Yes,
Please
ma'am.
go ahead.
Yes, ma'am.
Maybe
It's
then
okay.
there is some
Okay. So in these situations, we definitely say reduce weight before pregnancy. But once you're pregnant, then we're not talking of weight loss in pregnancy, but we're talking of a proper nutritional diet. We have realistic targets of weight over in the during the pregnancy, and we don't advocate bariatric surgery as a first prong. Lifestyle changes is most important. It's only in BMI above 35 with comorbidities. Those are the women where bariatric surgery is done, and of course they have to avoid pregnancy for 12 to 18 months. But with the advent of semaglutide and proper counseling, women are able to reduce weight. But again, all these things are the newer researches, and we are waiting for more and more evidence to come in. Underweight women, again, there's a problem because there are adverse perinatal outcomes. So please examine the food choices and find out, do they have anorexia nervosa and bulimia. But we do have underweight women coming in too, and therefore in those, try to fortify their nutrition before they get pregnant. And if they do get pregnant with that weight, again, the nutritionist advice is very, very important. Genetic considerations, consanguinity, heredity, advanced maternal paternal age, birth defects, patients with recurrent pregnancy loss, screen them pre, so that we can find out what exactly they have, and accordingly we can give them advice. Because most important is, once you modify that, give them the information, find out if a couple has had autosomal recessive or whether it is a autosomal dominant disorder, discuss about the impact of the disease, and then try to see whether we can modify it. And here a geneticist's help will be of great value. And then we move to optimization, which applies very, very strongly to us. India is known as the diabetic capital of the world. So if we can do this preconceptionally, nothing like it. But if they're already pregnant, then obviously screening for diabetes with the DIPSI criteria in pregnancy that's being followed in most of the places, giving them a good advice about medical nutritional therapy, and talking to them about if they don't follow this, there can be problems to the fetus, there can be problems to the mother during pregnancy, premature labor, preeclampsia, and all the entire problems. So therefore, these women are very, very important for us. And if they have pre-existing diabetes, most of the times they may come to you. Try to optimize their sugars and their glycated hemoglobin prior to the pregnancy. But if not, then we have to take use of either, if they're on insulin sensitizers, or shift them over to insulin. And we understand that diabetes is so important, and therefore even counseling them for the future pregnancies, lifestyle changes, very, very important. Discuss about contraception, lifestyle changes, meaning not just walking and reducing weight, but also a proper nutrition is very, very important to reduce the metabolic impact of diabetes. Now, obesity and diabetes almost go hand in hand, but it is not mandatory that every obese woman will have diabetes, but usually most of the time these would be a common association. Again, with a high BMI, there is a problem of hypertension, mental health issues, premature labor, and negative impact. And so, therefore, even the interventions by cesarean section are much more common. These babies are likely to be overweight. So, preconception counseling significantly helps, and that's where our wonderful gynecologists and obstetricians can be of great, great value. But once they're pregnant, then you have to do a vigilant antenatal surveillance, watch out for the complications, even simple things like urine infections, DVTs, conj anomalies, macrosomias, and timely referral to a well-equipped center because these pregnancies can be difficult. And friends, I want to say our women today are physically inactive. Get them to do regular form of exercises. And WHO recommends 150 minutes per week. That's not much. Just housework is not important. But encouraging physical activity, aerobics, good breathing exercises, group classes are very, very motivating. Now, hypertension. This is another very important subject. Please screen women for hypertension, essential, long standing. Try to achieve a target blood pressure of 140/90 if they are not yet pregnant. If they're already on anti-hypertensive, change over to safer medications. But in pregnancy, if they've come to you for the first time, please do a gestosis score because HDP is associated with higher risks and NCDs. And after PPH, hypertensive disorders are the next killer. So at the first visit, screening for BP, very important, particularly in the obese women. And I know everybody knows the gestosis score, but please just by heart it. Today, there are printed copies. Sun has produced a beautiful booklet for us, and these can be made available. This is there on the website. We've recently revised the FOGSI gestosis guidelines, and Sheila was also a part of it. So we have to make sure that this is done at first visit. If the score is 3 or more, these patients are positive. Start on low-dose aspirin and 1.5 grams of calcium. This score is to be used in every trimester because you can identify the risk. The best advantage of low-dose aspirin is before 20 weeks, before 16 weeks actually. But latest research is saying even 24 weeks you can add it. But after that, you can't add the aspirin, but you can see the risk, refer the patient to a higher center, do the split PLGF ratio. But remember, every visit is an opportunity for prevention. And this is available on the Android app of the gestosis score. And of course, we've got www.hdpgestosisscore.com. When you click on that link, you straight away get the entire gestosis score. And currently, let's not debate about 75 or 150. 75 is been used for long time. The trial between 75 and 150 will be coming out from Safdarjung by the end of this year. But please use low dose at night. Thyroid, another common problem, which is easily controllable. So friends, the international guidelines don't talk about universal screening. FOGSI guidelines is now recommending universal screening because correction can lead to better fertility outcomes, reduce the abnormal consequences, and follow it should not exceed 2.5 to 3 is overt hypothyroidism. Follow the American Thyroid Association guidelines, and the value has to be less than 2.8, 2.5 to 2.8. But if it is more than that, please start treatment. And once you change the dose of the thyroid that they're taking, please give them at least a chance to repeat it. Just give me 5 minutes more. Please give them a chance to repeat it after 4 weeks and hyper, of course, if there is a surgery formed, if this radioactive iodine, do not allow them to conceive. And anti-thyroid drugs, PTU in the first trimester, methimazole after the first trimester. Heart diseases, I won't go into too much of detail, but please do a CVS just as you're doing in RS. Check what the baseline cardiac conditions is. If there's anything requiring corrective surgery preconception, great. But otherwise, you'll have to take opinion of a cardiologist and give them advice. And of course, 2D echo is very important. 2D echo is also very important in a patient with hypertensive disorders. For autoimmune diseases, again, preconception folic acid. If there are any multiple anticonvulsants, shift to a monotherapy, and regular monitoring. Please keep checking the blood levels. Otherwise, if the blood levels form, because the liver functions very fast in pregnancy and they can be lower doses, so please keep checking the levels and take opinion of your hepatologist. And autoimmune disorders, I think we don't talk too much about it because everybody knows today about it. The patients are on methotrexate, cyclophosphamide, pre-pregnancy, change over to simpler medications. Some of these autoimmune diseases resolve in pregnancy and then again at puerperium they rise, but sometimes you can have a very devastating period during pregnancy. To take help of a rheumatologist, and the patient with recurrent pregnancy loss, the basic tests are to be done, but monitor them. But friends, there is no role of giving low molecular weight heparin in a patient with recurrent pregnancy loss if the APLA profile is negative. So don't unnecessarily, if they are thrombophilia positive, yes, there is a role. Mental health, please screen the patients in preconception period or during the pregnancy with the standard general health questionnaire. And if there are perinatal mental health issues, please take help, because there is a problem. They can do self-harm, they can harm themselves, and by that virtue, the baby incidence of preterm labor and FGR is very, very high. But please be confident, take help of a psychiatrist, treat them, address the stress of pregnancy and unidentified fears, and ensure family support and transfer to a tertiary care center. And just the last few slides, air pollution, drinking clean water, getting health checks, keeping the vehicle oil checks, using air purifiers, and planting more trees. We have to work towards reducing the air pollution. Cancer in pregnancy, please, when you're examining your patient, breast examination and one speculum examination is necessary. If there are any red flags, counsel the women and please leave them. Now, you have to think about a better tomorrow, and therefore, WHO has done a beautiful global monitoring framework. And I'm proud that India has taken up the control of NCDs. They've committed for 50% reduction in household use of solid fuel. And WHO says 7 targets. India has taken 9 targets to reduce. We must push them. Sheila, you and Bhaskar have to push them into prioritizing integration of NCD with MNCH care, so that in the first antenatal visit itself, we can look at everybody. Community-wise, all our committees can talk to the community. Facility, the multidisciplinary teams can help the overall health systems. And remember, we as obstetricians can play a brilliant role in reducing the NCDs. So integration of health services, whether it's horizontal, whether it's vertical, whether it's functional, all are important. But remember, integration is very important. And in conclusion, focus on preconception counseling, screen the patients, don't forget BMI, don't forget test for thalassemia, baki sab to aap lag kar loge, and don't forget thyroid. Treat it confidently. Preventive strategies are always good. Follow-up care. Don't forget anemia. Anemia is going to be there with us. So make sure they have a good diet and their hemoglobin correction. And today we also have, FCM to give them during pregnancy. And integration is not just a political choice. It is our association choice. And we have to push the government to make sure that these strategies are going to be in lead. Thank you very much. Sorry for over exceeding the time. Thank you so much. Thank you.
Thank you. Yes, Deepa?
Yeah, thank you, ma'am. And my naman to Guru Mantra, naman to all the gurus today here. And ma'am, I just want to incidentally, Suchitra Pandit ma'am, I belong to your college. And so in
Yes,
real sense, you are my guru, ma'am. I'm so blessed. And ma'am, you're absolutely right. We gynecologists and we obstetricians are the future guardian. And
Absolutely.
we have to take that opportunity whenever the patient comes for any problem to us, a newlywed couple or an unmarried girl. Yeah, like I just want to share, yesterday a girl, an unmarried girl, she had come to me with the complaints of dysmenorrhea only. And she just shared one thing, ki I have started smoking for last 6 months. So could this problem be because of my smoking? So I took that opportunity and I explained her the risk of the smoking for her future obstetric career. And she was literally convinced. So I feel also like it's our duty to give time to the patient, take a proper history, listen to their complaints, and then act accordingly.
Absolutely.
And
Sheila,
Dr. Arup,
I just wanted to share one thing. Professor Armida Fernandez, she was Dean of Sion Hospital. She's just got a Padma Shri. She would always say, whenever she's attended any of our gynae conferences, she would say, all of y'all are so active and so involved. So I'm sure that, you all have got the maternal mortality down, but I'm sure you all will also work on all the problems related to reducing preterm births. So I want to say that people outside know how committed we are. Let's just make all our colleagues do that.
I think that's really good. Dr. Arup, would you like to please add your comments as chairperson?
First of all, my thanks and gratitude to the chairperson and Dr. Sheila and Dr. Potik for involving me in the first inaugural session. And I am now in travel in these days. So what I heard from Suchitra Pandit, really the topics she has said beautifully. Can OBS gynae play a role in preventing NCDs? Actually, she wanted to say, and we can see, there is actually the majority of the obstetrics problems of the legacy of the non-communicable disease, the other problem. And she has started from the adolescence, she has started from the preconceptional things, and she has described the antenatal care also and genetic problem. So I am really, really happy, and is an excellent lecture, Dr. Suchitra Madam, Suchitra Pandit. I have very on long relation with Dr. Suchitra Pandit. I know her from the ISOPAR president and FOGSI president. Now is the representative of the FIGO. So really, I have heard many things and learned from this. Many things. I think now, Dr. Madam, you say something other chairperson, and also say.
Thank you, Dr.
I am
Arupmaji.
now concluded. And Sheila Madam, thank you for your for involving me at this beautiful and selecting this chapter, selecting these topics and sessions.
Thank
I
you.
will also
Every
like to
section.
say, I would like to just say my one line. And thank you, Dr. Sheila and Dr. Pratik, to give such a wonderful start to our ICOG programs with the Guru Mantra. And as the two wonderful gurus have taken us through most important aspects of our involvement in patient care, PPH and environment, and improving the health of our future, generations. So I'm really grateful to you all to include me in your opening program. Over to you, Dr. Pratik
I
and
think
Dr.
one thing, Dr. Suchitra, I know Pratik will have to speak now. We are starting that FIGO pregnancy passport. That is every patient, after the delivery, so that as her age advances, that continues, and like something like Meri Sehat Mere Haath, and making her aware. And we are many people have agreed upon to join, so we are going to start that in a big way, the FIGO pregnancy passport, and we'll see if we have to add something which is amenable to our country. We will go through it and see to it, so that we start doing it, and then the word spreads. So all of you, those who are listening today, you can access it even on a FIGO website, the FIGO pregnancy passport, because that will really throw light on these NCDs prevention aspect particularly. And a pregnant mother after delivery, she's with us and we can catch her easily. So that is what we are looking forward. And Dr. Pratik, over to you.
So thank you very much, everybody, for your fantastic contributions. I think we still have about 10 minutes left. So if there's any discussion or any of the GCMs who would like to speak,
I would like to thank Dr. Vidya Thobi also. She being here as a vice president, I think, of this year. Dr. Vidya Thobi is here. She can speak. Dr. Lakshmi, our past chairperson, if she is here, would like to say something.
I think Dr. Lakshmi is logged out, ma'am, but Vidya is here.
Yeah. I must congratulate Dr. Sheila Mane and the whole team of ICOG. I can see the enthusiastic all governing council member, and that is very
incredible what I feel. And the discussions were too good. And as you started with PPH, and then we started again and ended with the prevention of non-communicable diseases, which also included the screening of the high-risk pregnancies, which is very, very dear to us. So let us implement this year many programs under visionary Dr. Sheila Mane. And definitely the ICOG, the academic wing of FOGSI, along with this year's FOGSI team, we will definitely go further to contribute various activities. Thank you very much again for this program. I attended fully and I enjoyed the academics. Thank you.
Thank
Dr.
you, madam.
Sheila and Dr. Pratik, sorry to disturb. I heartily congratulate. I think well begun is half done. So we'll continue this way throughout, and I'm sure we're going to really rock.
Rock stars
Yes,
are here.
ma'am. Can I speak, ma'am, Dr. Anita?
Yes,
Yeah,
yes,
Here
Anita.
from Delhi. Ma'am, Suchitra, ma'am, it was a great blessing listening to you. I really liked the idea of giving letter of invitation to newlyweds for gynae consultant. It's a brilliant idea and it's so doable. Ma'am, even Delhi government has launched a small kit which is called Ek Nayi Pahal and which is given to newlyweds. It has got contraceptives. It has got one packet of emergency contraception and some iron and folic acid tablets. So that is a brilliant idea, and we all can carry this forward everywhere throughout India. It's a brilliant idea. I really liked it. Thank you so much for the great messages. Even Piley sir's brilliant presentation. So much to learn from that also. Thank you to Team ICOG for this wonderful academic session.
Thank you, Dr. Anita. Anybody else has any closing remarks, or should I propose the vote of thanks?
Dr. Pratik, congratulations for the wonderful initiative and really loved both the topic and Dr. Suchitra's innovation ideas. So better invite for tomorrow so everybody should be thus with the good
That's what I
spirit.
wanted to tell.
Yeah.
Dr.
So
Pratik,
please.
you can mention that.
Okay. Thank you so much, Dr. Sheila ma'am and Pratik.
I
Okay.
I
think I would like to say that today's session have been really good, and I think this should be a beginning for us, to take it across. Like I remember in 2015-16, we took MVA and EMOC across country. Personally, everywhere we went, and it.
I would like to thank Sheila Mane and Pratik sir for giving us this opportunity to be conveners for the inaugural session. So thank you so much.
Thank you so much, Dr. Sheila Mane and Dr. Pratik, for giving me this opportunity.
So we request all of you again to spread the word for tomorrow's fibroid masterclass. I think Dr. Pratik, if you can talk
Yes,
more
ma'am.
about it. Yeah.
So tomorrow's program
Pratik,
is
Pratik,
yes, ma'am.
before you give that, I just want to say ICOG has come of age. I can say that once you all start batting 8K PGA, sixers hi laga rahe ho. So you're already there on your second masterclass tomorrow. Congratulations.
Thank you, ma'am. Thank you so much. So we have the FOGSI ICOG Masterclass on fibroids, which is to be held tomorrow, Thursday, 29th of January, 4 to 7 p.m. The conveners for the program, Dr. Sarita Bhalira, who is our Vice Chairperson-elect, and we have the two coordinators, Dr. Ritu Khanna and Dr. Richa Singh, who've done a lot of work behind the scenes. We have 6 talks and a panel lined up. So everybody, all of you governing council members, request all of you to be present and spread the word in all your societies and all your groups. We want to see the same enthusiasm throughout tomorrow's program as well. And now, finally, if I can present the formal vote of thanks for today's program. Today has been a wonderful eye-opener session with two legendary stalwarts of OBGYN, the inaugural FOGSI ICOG Guru Mantra. My gratitude to the FOGSI office bearers, our president, Dr. Bhaskar Pal, who took time out from his busy schedule to be here. Dr. Suvarna Khadelkar joined us from the office. Parag and Sarita were there, of course, they're conducting the exam today. Thanks also to Dr. Ashok Kumar. Dr. Sadhna Gupta is here. And of course, I was a little late. I had to join from the road. We had two wonderful speakers, Professor Paili and Dr. Suchitra Pandit, both of whom are stalwarts of OBGYN and teacher of teachers, teachers of many of us here today. Thanks to the conveners, Dr. Saroj Singh and Dr. Shashi Bala Bhosle, two of our new governing council members, and they very closely coordinated with me over the past 1 week to ensure that this program goes off smoothly and flawlessly. Thanks to the chairpersons as well, Dr. Achla Batra, Dr. Pratibha Singh, Dr. Arup Kumar Majhi, Dr. Deepa Gupta, and Dr. Mitra Saxena also chimed in with a lot of good comments, suggestions, and of course, take home messages throughout the program. Thank you, everybody in the audience who attended, and I would also like to express my gratitude to all of you in the audience and the backend team of FOGSI ICOG, Nilima, Poonam, and the other backend team who's coordinating all of the FOGSI online activities along with ICOG. Thank you, everybody. Goodbye, God bless, and we will see you tomorrow at 4 o'clock.
Thank you.
Thank you, Sheila. Congratulations once again.
Thank you once again.
Thank you, ma'am. Fantastic program. Rocking start.
Yeah, and I must
Thank you,
thank
ma'am.
Nilima really, even though the exams are going on, I know we have really put them under a lot of stress, but those girls, I'll tell you, the office, they really work so hard and so meticulous. Okay, thank you, Nilima, and
Thank you,
everyone.
Sheila Madam.
Thank you.
Thank you, PPH
Thank you,
lady.
ma'am. Thank you,
Thank you,
sir.
Sheila,
See
ma'am.
you tomorrow.
And
Dr.
See you
Pratik.
tomorrow and spread the message,
Sure,
okay?
sure, sure.
Can we reach
And
out
we
next
do,
time?
Sure.
and we took pains to finish it in time.
Yes,
Yes.
absolutely. Before
We
time.
Thank you so much.
before
That
timing.
is the best
Yes.
thing. Yeah. Bye-bye.
Bye.
Thank
Bye.
you.
Bye.
Bye.
Thank you. See you tomorrow. Bye.
Bye. See you, everybody.
Shreya, stop the recording.
One pick for the Madam Sheila.